Hi, welcome back to my channel. This is Dr. Garima Verma, your very own Dr. Scrubs on Instagram, and I'm sorry I've delayed this recall series with First Aid for a long time now because I've been busy with my counseling and all that stuff. But now that I'm here, I'm back. Let's just start this series, and the subject that we are dealing with is psychiatry today. And this recall is based on first aid, and the annotations that I did were from Marrow Q Bank, and the questions that I've taken are also from Marrow Q Bank. So let's just start. And the first question was, a schizophrenic patient was prescribed drug A after he did not respond to haloperidol and thioridazine. He now presents with excess salivation and increased in blood glucose and hyperlipidemia. What is drug A? And the options were ziprasidone, risperidone, clozapine, aripiprazole. So you can see in front of your screens that this is a screenshot from first aid, the antipsychotics topic, and I have annotated it from my notes from Marrow. There are two types of antipsychotics, typical and atypical. Typical includes haloperidol, trifluoroperazine, fluphenazine, thioridazine, chlorpromazine, and atypical ones are second generation, which includes aripiprazole, clozapine, olanzapine, quetiapine, paliperidone, risperidone, and ziprasidone, and etc. and etc. So the main mechanism of action were they block dopamine D2 receptors, which increases CAMP. Atypical antipsychotics also block 5-HT2 receptors, and aripiprazole is D2 partial agonist. The clinical uses are schizophrenic. Typical antipsychotics primarily treat positive symptoms of schizophrenia, and atypical treat both positive and negative symptoms. Disorders with concomitant psychosis like bipolar disorders, Tourette syndrome, OCD, Huntington's. Clozapine is used for resistant psychotic disorders or those with persistent suicidality. Close to the edge. Clozapine close to the edge means suicide. The adverse effects include antihistaminic, sedation, anti-alpha-2 adrenergic, orthostatic hypotension, antimuscarinic like dry mouth, constipation, anti-ham, use with caution in dementia. The metabolic disorders include weight gain, hyperglycemia, dyslipidemia. It is highest with clozapine and olanzapine. Okay, let's just see in our Q bank. It is given excessive salivation, increase in blood glucose, and hyperlipidemia. So hyperlipidemia, metabolic में weight gain, hyperglycemia, dyslipidemia. ठीक है, highest risk with clozapine. So you can see where I am heading. Endocrine disorders, adverse effects include hyperprolactinemia, galactoria, oligomenorrhea, gynecomastia, maximum with risperidone. Cardiac side effects include QT prolongation. QT is equal to quetiapine. That is how I learned it. Neurological includes neuroleptic malignant disorders. Ophthalmological, chlorpromazine हम ऑप्था में भी पढ़ते हैं, कॉर्नियल डिपॉजिट्स होता है, रेटिनल डिपॉजिट्स होता है, कैटरैक्ट होता है क्यूटियापिन के साथ, एंड क्लोजापिन के साथ आपका ए ग्रैन्युलोसाइटोसिस होता है. सो यू हैव टू मॉनिटर योर WBCs रेगुलरली, क्लोजली. लाइक वी लर्नड close to the edge, clozapine, यानी suicide में we can give clozapine. A granulocytosis, closely monitor WBCs यानी clozapine. So these things and extrapyramidal side effects include ADAPT, as today's acute dystonia, oculogyric crisis. This oculogyric crisis is asked in previous year topics also, and the treatment was asked, and the treatment was promethazine. I have learned this question a number of times now. The treatment includes benztropine, diphenhydramine, promethazine also. ठीक है, and there's 2 months akathisia and Parkinsonism. So the treatment according to that. And you can see I have written side effects also here. Sublingually treatment में we give acinapine, and some say clozapine has too many nasty side adverse effects. ठीक है, SSCH, seizures, sedation, constipation, hypotension, tachycardia, mass increase means body weight increase, nausea, vomiting, agranulocytosis, enuresis, and polyuria. And the question it was given excessive salivation, increased in blood glucose, and hyperlipidemia. So the metabolic side effects, which are basically due to clozapine and olanzapine. Olanzapine is not in the question is not in the options, so the answer would be clozapine. Believe me, it is a very easy question and I have written it very beautifully, and yet I marked it wrong in NEET and I both. I don't know why I do this, but I marked this question wrong. So let's move to the next question, which is a woman who is 4 days postpartum presented with tearfulness, mood swings, occasional insomnia. What is the likely diagnosis? I think this question has been also asked in NEET 2022. This is a very easy question and you should not get this wrong. This has been asked a number of times now. The options were postpartum depression, postpartum blues, postpartum psychosis, and postpartum anxiety. Let's read this screenshot. Peripartum mood disturbances, onset during pregnancy or within 4 weeks of delivery, increased risk with history of mood disorders. There are 3 disorders in this: postpartum blues, MDD with peripartum onset, जिसको we call postpartum depression, and postpartum psychosis. So postpartum blues is very common. You must have heard it or you must have read it in Obs Gynae also. Like I remember Sakshi ma'am has taught in Obs Gynae also. 50 to 85% incidence rate, characterized by depressed affect, tearfulness, fatigue, starting 2 to 3 days after delivery. Read the question again. 4 days postpartum, tearfulness, mood swings, occasional insomnia. I think you know where the answer is leading you. It's postpartum depression, of course. Treatment is supportive. Follow up to assess for possible MDD with peripartum onset. Okay. Now this is peripartum depression, postpartum depression, postpartum blues symptoms persisting for more than 2 weeks. Is postpartum depression. It starts within 12 weeks of delivery and thought of harming baby are there. Postpartum psychosis, 0.1 to 0.2% incidence rate, characterized by mood congruent delusions, hallucinations, thoughts of harming a baby or self-harming also. Risk factors include first pregnancy, family history, bipolar disorders, psychotic diseases, recent medication change. The treatment is hospitalization. You have to hospitalize the patient, and initiation of atypical antipsychotics. If insufficient, ECT can be used, or treatment of choice will be lithium, antipsychotics, antidepressants. So the answer to this question is postpartum blues. Right. Now the third is a 25-year-old female reported symptoms of anxiety, palpitations, sweating, breathlessness, chest pain, and feeling of impending doom. She recalls having experienced 5 to 6 similar episodes in past 6 months, each episode lasting for about 20 to 30 minutes. What is the likely diagnosis? The options were depression, panic disorder, general anxiety disorder, and phobia. So just let's read the screenshot here. Panic disorder. Answer is panic disorder. You must know this. Sweating, breathlessness, chest pain, feeling of impending doom is the keyword here. And you know it isn't panic disorder. So just let's read what is given in first aid in panic disorder. Recurrent panic attacks involving intense fear, discomfort, plus minus a trigger. Atypical attacks typically peak in 10 minutes with more than 4 of the following problems: palpitations, paresthesias, depersonalization, abdominal pain, nausea, intense fear of dying, impending doom, intense fear of losing control, lightheadedness, chest pain, chills, choking, sweating, shaking, shortness of breath, strong genetic component, increased risk of suicide. And you see here palpitation, sweating, breathlessness, chest pain, feeling of impending doom. These all are the symptoms that have been described here. So diagnosis requires attack followed by more than equal to 1 month or more than equal to one of the following, which is persistent concern of additional attacks. Means person will think कि अब दोबारा तो नहीं हो जाएगा, दोबारा तो नहीं हो जाएगा. So it is a concern for him. Worrying about consequences of attack, he'll keep worrying ki what will be the consequence, kya hoga, kaise hoga. Behavioral change related to attacks. Believe me, I have been very close with a person who had panic attacks, and it is not funny to have panic attacks, and you should not make fun of a person who is having panic attacks. It is very, very disturbing for the person who is having it. So just be there for that person. Treatment includes CBT, SSRIs, venlafaxine. This venlafaxine has been asked in AIMS exam also. These are first line treatments. So this is it. So this is how you read, and this is how you, like venlafaxine, I have written AIMS on it because it was asked in AIMS once. And now the fourth question is, a chronic alcoholic is brought to emergency department with confusion, ataxia, painful eye movements. Sixth cranial nerve is also involved. What is the likely diagnosis? Confusion, ataxia, painful eye movements, and the sixth nerve involvement. The options were Wernicke's encephalopathy, Korsakoff psychosis, delirium tremens, D. Clermont syndrome. So just let's read alcohol use disorder from first aid. Diagnosed using criteria for substance use disorder. Complications: vitamin B1 deficiency, alcoholic cirrhosis, hepatitis, pancreatitis, neuropathy, and testicular atrophy. Treatment, we all know naloxone reduces craving, acamprosate, disulfiram to condition the patient to abstain from alcoholic use. Support groups such as Alcoholics Anonymous, etc. etc. So, and now we read about Wernicke's Korsakoff syndrome. B1 deficiency precipitated by administering dextrose before vitamin B1. So this is a very important question, ki you should not administer dextrose before vitamin B1, otherwise it will precipitate Wernicke's. So we give B1 followed by dextrose. So very important. Triad of confusion, ophthalmoplegia, ataxia. So this is the triad that is given here: confusion, ataxia, painful eye movements, and sixth nerve involvement, ophthalmoplegia. So Wernicke's encephalopathy. Wernicke's can progress to irreversible memory loss and confabulations, personality change, and then we'll call it Korsakoff syndrome. So the treatment is IV B1 before dextrose. ठीक है. Korsakoff syndrome में there is confabulations and anterograde amnesia, and this has been asked in INI 2021. So there's so many questions, they keep repeating the same topics. If you see, I have written INI 2021 here, and let's study the table that I have made here. Manifestations: tremulousness, tremors 6 to 8 hours after the last unit of alcohol. Then alcoholic hallucination, psychotic and perceptual. This is intact orientation. Sign and symptoms is intact orientation, and it is in 8 to 12 hours after the last unit. Seizures, GTCS type of seizures, 12 to 24 hours. And then there is delirium tremens, impaired orientation, less than 72 hours. Delirium tremens mein na, they'll give you a history of alcoholic patient admitted in ICU, and within 3 days of his admission in ICU he is experiencing tremors and all that stuff. That is typically delirium tremens, because kya hota hai ki we admit the patient in ICU, is not getting alcohol, so of course there will be withdrawal and then tremors and delirium tremens. There will be the typical history of patient admitted in ICU or in hospital, and within 3 days of admissions he develops tremors, or was an alcoholic patient, and it will be delirium tremens. So there's so many questions that has been asked from this half a page, not even half a page, 1/4 of a page. So this is very important. And now fifth question, the last question is, a middle-aged man complains of very high ejaculation during during intercourse. What is the non-pharmacological management that can be advised to the patient? Early ejaculation. Okay, so the options were cognitive behavioral therapy, exposure and response prevention therapy, squeeze technique, sensate focus therapy. Okay, so let's read this sexual dysfunction wali slide. Includes sexual desire disorders, hypoactive sexual desire or sexual aversion, ठीक है. Number 2 is sexual arousal disorder, erectile dysfunction. Number 3 is orgasmic disorders like anorgasmia, premature ejaculation. You have heard in this question early ejaculation. Early ejaculation means premature ejaculation. Sexual pain disorders, genitopelvic pain, penetration disorder. See, in this premature ejaculation I have also written NEET-19. NEET-19, that means this question has been asked in NEET-19 also, and I have annotated it also कि treatment for premature ejaculation is Siemens technique, stop start technique, squeeze technique, sensate focusing, SSRIs. And in this question they have given squeeze technique. That means the same question was repeated in NEET 18 also, and it has been repeated in NEET 23. So now you understand how important these previous year questions are, and the answer is now squeeze technique. So these were the 5 questions that were asked from psychiatric portion of first aid, and I hope it was helpful. And if you want the PDF for the same, then you can drop me a text on Telegram also, Dr. Scrubs, and I'll send you the PDF. Or you can join my channel on Telegram, which is Dr. Scrubs. I'll send you this entire PDF, and I hope it is good. Want more such videos, then comment, and I hope it will help you in any way possible. So if you like this, like, share and subscribe so that I can make more content like this for you and help you guys. So all the best and take care. Bye bye.